Thank you for joining us. My name is Mark White. I'm the CEO and president of the Work Wellness and Disability Prevention Institute. We are a national charitable organization headquartered in Vancouver, British Columbia, Canada. This is an updated presentation to one that I presented at the BC Chapter Vocational Rehabilitation Association's annual general meeting on October 26, 2018. The focus of this talk is on psychosocial factors contributing to delayed return to work and promising interventions. I'll first provide some information about Work Wellness and Disability Prevention Institute to provide the context for the research I will later present. I'm asking you to consider the broader context of workplace health in relationship to chronic disease and organization culture. I'll discuss findings from our research synthesis activities, followed by a case study that provides an example of looking beyond compensable versus non-compensable injuries, and what the potential consequences are for workplaces and compensation boards. I'll lastly share some research findings from other researchers. So the mission of the charity is to create safe, healthy, productive, and inclusive workplaces that people with injuries, chronic and episodic health conditions want to stay at work or return to work. As part of our mission, we want to fast track what is known from high quality research and to move it into policy, training, and practice. We're a unique stakeholder organization, and our goal is to provide credible, science-informed, practical tools and education resources. We work with government, organizations, employers, labor, academic centers, insurers, service providers, and individuals who play a role in policy, training, and practice. There are many players involved in employee health and workplace wellness. And this diagram just shows the complex relationships between both employer actors as well as external actors that have an impact on addressing both mental and physical injuries at work. One of the vehicles we use to fast-track research is through our free public access webinar, Research to Practice webinar series. We have speakers who are researchers across Canada, the USA, Europe, UK, Australia, New Zealand, who participate in this program. These webinars are free, and we welcome your participation in the webinars. And we also thank the growing number of professional organizations and associations who co-host or co-sponsor our webinar series. So we have quite a range of webinars, from mental health, occupational health and safety, musculoskeletal, as well as chronic disease. So the first question that I think we need to consider is whether or not we're barking up the right tree. Do we really understand challenges employers and employees are facing? And are vocational rehab specialists ready, knowledgeable, skilled, and to be part of the solution in the future? For too long, I think we focused on just a few trees and may not be seeing the full forest. The focus on just addressing compensable versus non-compensable injuries is very problematic. And later in this presentation, I'll present a case study demonstrating how we need to reconceptualize and understand factors contributing to workplace absence. I think we also need to consider which evidence that we're looking at. What are the causes of prolonged work absence? And what is the scope of research evidence should we be considering? As well as what is the quality and strength of the research evidence supporting potential solutions. Given the high prevalence of major chronic and episodic health diseases in Canada, how do these diseases impact return to work? 1/3 of the population of Canadians have at least one major chronic health disease, and 1 in 7 have 2 or more chronic health diseases. The daily rating is a research statistic that considers 2 factors. Years of life loss due to premature death, coupled with years of healthy life loss due to disability. This slide looks at change from 1990 to 2016 for the working age population, 15 to 49-year-olds. I think that it's interesting to note that in terms of disability ranking, mental health disorders was there in 1990 as number 1 and remained so in 2016. We'll see that there's been a slight change in the ranking between 1990 and 2016. But it's important to think about this just in terms of this is the younger workforce and what happens when we look at the older workforce as we have an aging population. This slide just provides a visual representation of chronic diseases between 15 to 49-year-olds. And you can see depression, drugs, anxiety, back and neck. But things change between 50 and 69. And I think that we need to consider that when we're looking at an aging population in terms of a workforce, and also the thought that it's the aging population that's going to fill the growing need for employees as we have a lower birth rate. And the question that we have to ask is, are workplaces really ready to address the needs of a greater part of their workforce having chronic conditions? Here we can see that cancer is number 1, and cancer for the most part now is considered a chronic health condition, as the survivor rates are quite good for many types of cancer. It's also interesting to note that in this age range, mental health disorders falls to 4th ranking from first. And you can see the rise of cardiovascular disease as well as diabetes, which is also an important factor when we consider general population health and workplace health. And this just gives a visual representation, again, showing the types of cancers. But you can still see that depression, anxiety, back and neck, and other musculoskeletal areas are present. But you can see the growing group of diabetes and migraine is less within this working age as well, 50 to 69. So I'm asking the question, about what are the implications of chronic disease in an aging population for rehab professionals and the workforce, and what new knowledge and competencies do you need to add to your toolbox, and what evidence-based services can you offer employers directly. When you consider that chronic disease alone costs Canadian society more than $90 billion in lost productivity and healthcare costs, this is an important issue for employers, and I think will become increasingly important to address. So I'm now going to share some of the findings from our research synthesis activities. And following meetings with a broad range of stakeholders, including HR professionals, service providers, insurers, disability coordinators, we collectively decided that we wanted to do a best evidence synthesis of systematic reviews on what do we know about risk factors across different health conditions and populations, contributing to prolonged work absence across health conditions. After we did that synthesis, the working group also wanted to then explore what do we know about workplace interventions that impact these identified risk factors. And finally, I'll present some preliminary findings related to our current project on identification, prevention, and control of psychosocial hazards and social conditions contributing to mental health disorders. So just to provide sort of an understanding of what we did, we have individual studies that may look at a particular intervention, for instance, looking at one or two interventions for people with depression in the workplace. And a systematic review might then look at what do we know about all interventions that address, let's say, depression in the workplace. And it weighs out both looking at the quality of the research design and quantifies the level of strength and confidence or consistency of aggregated results across the range of studies that address that issue. What we did is we then did a best evidence synthesis, and we looked at all the systematic reviews across health conditions to look at what do we know about and what can we learn about interventions that could have an impact across health conditions, and that's the part of the results that I'm sharing. This particular first group was looking at risk factors. So risk factors contributing to prolonged work absence. And the important aspect of this was that the working group stakeholders were saying that it appeared to them that many employers were doing flavors of the month in terms of the types of interventions going on in their workplace. But by actually having an understanding of risk factors driving prolonged work absence, it provides an opportunity to then look at, are these particular interventions that happen all the time within workplaces, are they really directed at the risk factors contributing to prolonged work absence? So the important thing about this diagram is just to show that we systematically looked at the literature. When we did the identification of citations that had systematic review and risk factors as part of our search criteria, we found 2,467 citations. And then we eventually, in our review based on our inclusion and exclusion criteria, found that there were 37 systematic reviews that addressed the factors that we were interested in. So we were interested in risk factors that contributed to work absence. And so the systematic review had to look at sickness absence, return to work, our costs, our work productivity in order to be included. When we use the term strong, moderate, and weak, we are using these terms in relationship to the number and quality rating of systematic reviews that investigated this relationship. In some cases, some things labeled moderate or weak are indicative of the lack of systematic reviews investigating this factor, whereas all of these factors were identified as predictors and risk factors in the literature, but may not be common across 2 or more health conditions. So those that are strong, if we look at them, low social support, low job satisfaction, low supervisory support, low worker control, an increase in psychological demands, an increase in job strain. So job strain is when there's an increase in psychological demands and there's low worker control, or an increase in physical demands. But those in the moderate range are also important to consider the nature of precarious work, and that's non-full-time work, issues around the quality of leadership, the sense perceived justice or whether or not people felt they're being treated fairly, and low managerial involvement as well, were all considered risk factors across health conditions, 2 or more health conditions. These other factors were identified in the area of insufficient, where there just was not a sufficient number of systematic reviews identifying these risk factors. Whereas in some cases, there was just in what was available, the findings were inconsistent, and that would be in the case of compensation and insurance level, as well as sort of a wider net of what we've called intervention approaches, which are a bit of a mixed bag. If we look at now modifiable worker factors, we can see here we're looking at increased emotional distress and depressive symptoms, maladaptive enduring psychology or personality factors, such as narcissism, for instance, negative health and disability perception and negative recovery expectations. This is probably one of the strongest predictors, is whether or not the worker believes that they will be returning to work in a timely fashion. A decrease in general physical activity, a decrease in family support, a decrease in general health, a low motivation to return to work, increased number of disability factors, and including increase in pain and increase in fatigue, but also sleep difficulties and substance use were across the systematic reviews as predictors. So in the second review, we now wanted to look at what do we know about workplace interventions that impact these identified risk factors. So we went through a similar process. Here there were 3,363 citations after the duplicates were removed. And we found 46 systematic reviews met our eligibility criteria. So here we found consistent evidence that work accommodation, stakeholder engagement, and social support were all key components that were predictive of better return to work outcomes. So early contact with the worker by the workplace, participation of a return to work coordinator, offers of work accommodation, and contact between healthcare providers and the workplace. And we found moderate evidence that each of these factors led to a reduced disability in terms of duration and costs. But cumulatively, they each added to an increase an increase in supporting early return to work. We found that job control and job demands were also predictive factors. So reducing job demands for off-work workers with musculoskeletal pain facilitated return to work, and there was strong evidence. And it also positively impacted sick leave, work productivity, and financial outcomes. Increased job control, we found, also reduces sick leave and absenteeism among general workers. So increased job control enhances work productivity and performance as well. In the psychological interventions, we found that interventions that are focused on improving psychological coping were helpful in improving work outcomes in off-work workers. There's limited evidence there. Fairly consistent evidence that interventions utilizing cognitive behavioral therapy or had a behavioral components had a positive effect. And interventions to improve mental health for general workers are helpful in improving work outcomes. There is a lack of high-quality primary research around psychological interventions, and we think that as the interest and research continues in this area, we'll see stronger research evidence results. We also found that physical activity interventions may reduce sick leave or work absence for general workers, particularly those with low back pain. So use of short, simple exercises or fitness programs, that these were just as effective as more complex physical activity interventions. And so from just a cost-benefit perspective, you don't have to have complex fitness programs to make a difference. You can use simpler providing access to fitness or promoting exercise during breaks, lunchtime, buddy programs, those types of things. For workers off work at baseline with subacute low back pain, however, requires more comprehensive interventions, and must be the more effective programs are those that are a combination of clinical and occupational integrated programs where there is strong connection to the workplace and good communication across all partners. I'm now going to share some of our preliminary findings that are top secret from our current research project, Identification, Prevention, and Control of Psychosocial Hazards and Social Conditions Contributing to Mental Health. This involves 60+ systematic reviews, and the reviews were on topics such as wellness, mental health, stress, work design, musculoskeletal, disability management, occupational health and safety, and substance use. So a fairly broad range of systematic reviews were included. I'm just going to share a couple of results, but in the area of job control that I had mentioned earlier, here you can see that job control can have quite a positive, when we look at the interventions, can have quite a positive role in sickness absence, costs. So you have 68 interventions that were positive, 14 with no effect, and 2 that were negative. On the cost side, 21 and 3 of no effect, and productivity, 25 versus 5. So there's very little downside to doing these interventions, whereas there is a much greater likelihood of them having a positive impact. In terms of presenteeism, really there is not that much research around presenteeism, although there's a good discussion around it. The construct is difficult to measure, and so I think that we'll see in future research this area being explored more. I should mention that this is raw data, and several of the systematic reviews are referring to the same primary studies. And so these numbers here are an overestimate. However, this shows still the trend, and the numbers above will be adjusted. So we found that there was strong effects of employee participation activities and increased job control, improving a range of factors. So employers who fostered collaborative problem solving and took action, reduce sickness absence, improve work productivity, and improve the working conditions. And we found that there's a cascading effect on collaborative problem solving approaches that may lead to positive changes both in job control, job demands, social support, job stress, and mental health. In these cases, labor management partnerships were key, and they had to have some ground rules to make them effective. They had to be democratic in terms of participation of both labor and management. There had to be an inclusive process that involved problem identification, problem clarification, and resulted in recommendations for action. It needs to involve employees and managers or supervisors in the committee, and it may be guided by an experienced facilitator or trained staff. It must result in some real change to be effective and sustained, and requires renewal on a regular schedule. That could vary from quarterly, semi-annual, or annual, or working on a specific problem that would require more frequent meetings. We also that these types of participatory approaches can identify workplace conditions that contribute to stress, e.g. psychological or physical demands, and could impact job control, social support, etc. as well. And collectively, this process identifies opportunities to reduce those stressors. Now, this is also includes identification of hazards and controls around those hazards as well. So as part of our results, we saw that participation in the identification and control of stressors, that these types of participatory approaches can have an impact. They typically result in some level of increased job control. This could be flexible schedules. It could also be self-managed teams, self-managed schedules, moving to more of a primary nursing perspective. We also saw job redesign aspects. So these could be ergonomic assessments and adjustments, increasing task variety, having an impact on shift rotations, increased mini breaks, but also skill development. Really, and I'll talk a little bit more of that in the stress management training. So we have typically thought about stress management training as mindfulness or biofeedback or yoga, but or specific stress reduction techniques, relaxation. But actually, stress management training can also be increased training around problem solving or time management, or dealing with difficult clients, or resilience training that specifically focused on some work activity. So it's not just the notion of stress management, it's really, are we providing sufficient skills for workers to better cope and manage their work. When we look at social skills training, empathy, communication training, there's studies addressing peer care, and we'll probably do some webinars in the future in that area. Leadership training, emotional intelligence, or assertiveness training as well may be relevant. In terms of health awareness education, mental health education, nutrition, fitness, exercise, lifestyle, health risk assessments can all have an impact in terms of general wellness on the workplace. But the others could be strengthening the health support programs, and these could be strengthening EAP programs, more cognitive behavioral therapy, more specific counseling dealing with both individual and workplace stress, smoking, diet, alcohol, etc. Exercise programs, telephone support, as well as providing online, either online or at work support in terms of integrated care, are providing care and training at the workplace itself. From an employer perspective, an absent worker is an absent worker is an absent worker. And I'm going to share some information on a case study that sort of provides an example of on how we might want to conceptualize addressing these risk factors and to get a sense of what was done in practice. So we can see that most work absences are related to non-compensable injuries or chronic health conditions versus compensable injuries. So from an employer perspective, it's really important, if we're wanting to provide value to employers, that we're actually looking at what are the drivers of work absence within a workplace, and how do we create solutions that best address that. So I'm asking the question, do our solutions really address the scope of the problem? And I'm going to provide sort of a case study where that involved BC Transit and WorkSafe BC to provide sort of an example of this in action. So BC Transit is the provincial public transit sort of authority. It serves over 1.5 million people in 130 communities. It has contracts with 30 operating companies, carries over 51 million people annually, and has 1,100 buses. It's a large in scope organization. It has 525 transit operators, 90 mechanics and support, and there are 200 office staff that are oversee sort of contracted operations for the 130 communities. Now, the average age of the workforce is like many of our workforces at being 50 plus. Job demands are high, both in terms of long durations of sitting for operators, as well as physical exertions for mechanics. There were stressed relationships with the union and limited interaction between supervisors and employees. And that's due to a lot of the employees being out in the field. But from an occupational health and safety perspective, things were looking not too badly. The blue line there is actually the BC Transit base assessment rate versus the standard for the industry was higher. So if you just look at the occupational health and safety side of things, you get one perspective. However, the big problem here was the escalating occurrences and length of absences, predominantly non-occupational and recreational in nature, as well as an increasing number of repeat injuries, with over 200,000 hours of time lost to injuries and illness. So it's a very significant cost, as well as a decrease in work productivity, as obviously if a person is off work, there's no productivity. So in 2012, WorkSafe BC began exploring ways to improve early return to work outcomes, and a team was formed, and the latest return to work research was searched to identify, was there a return to work standard that could assist them? In the absence of finding a return to work standard, a team of occupational health physicians, PhD students, registered nurses, senior psychologists, researchers, and other subject matter experts created a work disability prevention standard that incorporated the current best practices and disability prevention principles. They then also developed a comprehensive audit tool to evaluate employers' injury management program against the new standard. And as part of this development process in 2014, they approached BC Transit to assist them in developing and piloting this new participatory approach to return to work. So the standard was based on the following guiding principles: senior leadership commitment, early intervention and disability prevention, accommodations and offers of modified work day of the injury, a focus on function, supervisor and co-worker support, early ongoing contact with the worker, a participatory approach and worker-centered approach, collaboration with stakeholders, and a biopsychosocial approach rather than a biomedical approach, as well as to create a evaluation process to look at something that's both evidence-based and measurable to ensure continuous improvement. In the case of BC Transit, the strategic initiative began with senior leadership commitment from the CEO and vice president levels from both WorkSafe BC and BC Transit, where each organization brought to the table senior VP level sponsors, business leads, project managers, subject matter experts, communication teams, as well as the employer's senior union partners. The audit tool was developed looking at policies, practices, review of worker case files, audit interviews, and a document review. And they wanted to look at audits throughout each of the various phases to be able to measure improvements and baseline. So as part of the pilot, WorkSafe's Work Disability Prevention Project staff shadowed BC Transit's audit of their disability management practices, which was part of an earlier WorkSafe BC program. And in addition to looking at document reviews, they also conducted 75 interviews with 2 work disability program auditors. The audit report showed that there was a strong commitment and support at the executive leadership level. However, there was a lack of standard policies and processes. There was also a significant gap where accommodation was not well matched to functions. Most of the other components of the audit were low scoring, and those included the biopsychosocial approach, awareness and competency, the worker-centered and participatory processes, etc. So how do these principles translate operationally? Each part of this process was created collaboratively via work groups, including content experts. And you notice that in the center of this entire process is, most importantly, the worker who, with the support of their supervisor, was recognized as being key to the success of this process. So early identification of an injury when a supervisor notices a worker having difficulty performing their jobs due to signs or symptoms of an injury, or a worker reports an injury to a supervisor, that this was recognized as the early opportunity to be proactive. And so early intervention then meant the day of the injury, not days or weeks later. And early intervention could look at a number of things. The first thing might be to get the worker to their first aid attendant for those workers not needing urgent medical attention. It may be a referral to a physiotherapist for a functional assessment for sprain and strain injuries so that the employer and worker can match safe and suitable duties to allow to recover at work. It may mean making some workplace adjustments, such as ergonomic changes, or it could be a supervisor change if it is a relationship issue. Or other appropriate referral to healthcare professionals, such as a GP. It is the timing that is really key. So day of the injury or next day is the target. Thus, we've set up with some WorkSafe setup with large employers direct access to physio, either, for instance, on a large construction project site or close by. And in this case, it was on site at the facility with BC Transit. So it's progressing to the concept of the worker staying at work, or just or if it was necessary to have a short time off work, returning to modified duties as needed, and then successfully progressing the worker to full-time hours. But a part of that was also monitoring the worker over a period of time, weeks to a few months, to be able to react if the worker has a flare-up or is going back a step or two, to see if a physio or medical referral would be appropriate, or if temporary modified duties would prevent the worker from being disabled from doing work. At the core, though, is really providing appropriate accommodations. And through their working groups, they created job jars. So they looked at different types of injuries, back injuries, for instance, knee injuries, shoulder injuries, and then created job jars, or looked at examples of modified duties that were built together with labor and management to looking at things that were more functionally relevant to that worker and their job. The unique thing about this project was that it was for both workers with compensable injuries as well as non-compensable injuries. And an important aspect was that there was no cost for providing these services to the employee at work. So the critical aspect of the process was the engagement of labor and management and leadership in the collaboration with content experts. And so working groups were developed for each key focus area: policy, roles and responsibilities, training and education, communications planning with a monitoring and measurement plan, developed with leading and lagging key performance indicators. So key deliverables were identified for each group, including the development of a work disability program policy, goals, roles and responsibilities defined, process guides with supporting resources and tools developed, contracts in place with direct access to physiotherapy with KPIs monitored, training and education plans executed, and phased implementation for each of the functional groups to develop best practices leading up to the largest cohort, which were transit operators. Communications plan included a strategic name, stay on board, and intent developed, and communication materials and logistics were implemented, as well as the work disability prevention audit scheduled. From a communication perspective, the employee, the supervisor, the union, employer, insurer, healthcare provider, all had roles to play that needed to be understood and fully developed. There was the recognition of the benefits of the partnership for the employee, for the employer, the union, and WorkSafe BC itself. It did require changes. From the labor perspective, they recognized a major culture change. Before, if you were injured, you would go to your doctor, you'd go home and rest and recover until you were cleared to return to work. But the labor leadership recognized that being at home with an injury can actually impact recovery. It can cause financial problems, loss of experience and knowledge, as well as family issues. So it was important, and it took a while for changing the culture and mindset of the injured worker. And part of that was recognizing that the focus is now on remaining at work during active recovery for both work-related and non-work-related injuries, rather than focus on returning to work after recovery. Access to immediate treatment was really, I think, a very strong element that brought people on side to this notion of recovery at work. And it also, I think, more importantly, created a more positive recover at the work relationship. where there was the employer and member ensuring that they have the support they need in the active recovery process, and a continued and improved work disability program was key. From the labor perspective, they noted that it removed the waiting game. Wait for the injured worker to see the doctor to get a note. Wait for the worker to tell the employer they're not coming in. Wait for WorkSafe to receive and make a decision on a claim and a referral to physiotherapy. Wait for a doctor to decide when a worker can return to work. Wait for alternative duties. Wait for WorkSafe to create a return to work plan, and then wait for the doctor's clearance for a full return to work. By providing immediate access to appropriate services, avoided much of the waiting game. So the results were fairly impressive, although it was not a research study. But if you look at the results, so 150 employees participated in the Stay on Board program. There were 90 functional assessments completed, 106 workers remained at work or returned to work the next day, and 21 workers returned within 5 days. 6 workers returned within 4 weeks, and 78% have remained in a work plan. And then when you look at it from a 1-year perspective, you can see that that trend line has now taken a downward trend rather than continued upwards. So fairly impressive results. And from what I understand, millions of dollars in savings. Learning from others. I'm just going to share a couple of other slides, and this came from a webinar that William Shaw did as part of our webinar program. And within the research field and workplaces, we're seeing the benefits of moving away from the typical biomedical approach to disability with a focus on individual factors to practices focused on workplace factors and worker factors as being important for facilitating early return to work. In the case study I presented with BC Transit, you can see that it was more of a bottoms-up process, similar to this, where the worker and supervisor is key at the center of it, and involved in a process of understanding the job tasks, having a functional assessment to identify limitations, and then to find appropriate modified duties and accommodation in addition to ongoing treatment. William also mentioned that looked at each of the various levels that required involvement in a successful return to work program. So at the worker level, perceptions of physical demands and psychosocial demands. At the working group level, co-worker support, health and safety, good, solid health and safety practices. At the supervisory level, support for job modifications and communication. And at the managerial level, proactive return to work policies and practices, and a commitment to workplace health and safety. There's clear evidence that job accommodation works. It doubles the likelihood of return to work. It reduces disability costs by half. It involving both workers and supervisors is critical. Most of the costs are administrative in nature, and it's low cost. It does involve some brainstorming and interactive efforts. The interesting thing that Dr. Shaw mentioned was that only 2/3 of the recommended accommodations are actually implemented. He also presented research on supervisory training that showed good results following 4 hours of training. With the training looking at some key aspects, inviting early complaints, listening to the worker concerns, providing support and reassurance, maintaining contact, engaging in some collaborative problem solving, analyzing job tasks, suggesting modifications, and coordinating with HR. And you can note that this was also looking at a participatory ergonomic approach. And you can see pre-training and post-training results. And satisfied with the supervisor was a significant leap from 68 to 83%. The 17% and 5% felt blamed and discouraged from filing was no longer present with the post-training. And took my pain seriously, a 20% increase. Talked with me privately, a large jump. But actually help to modify my work was fairly low, 45 to 57%. But help to decrease discomfort was quite high, almost double, from 44% to 80%. This is very encouraging results, particularly seeing that it was only involving 4 hours in total in terms of training. So in conclusion, from an employer perspective, an absent worker is an absent worker is an absent worker, and that the separation between compensable and non-compensable injury is really an artificial construct that can have limited impact on employer real costs and employee health. I think that there are opportunities for vocational rehabilitation specialists to provide direct services to employers to address an aging population. And I think we need to consider what skills and competencies are needed to help employers improve workplace culture, work productivity, and employee health. I also think that there are roles that VR specialists can play and do play in the disability prevention arena. I've also included in this presentation that you will have access to the slide set, some research resources that you may find of interest. Thank you very much.